amazing talk. I think you'll agree with me that it was good for us that Dr. Ferries decided not to go into a career of singing. And the entertainment industry misses you, but we're very glad you're there. So I'm going to end with just a discussion about the next frontier. And I sort of regret picking this title because we're at the next frontier already. And it's interesting we ended with a picture of the Duke. But what I'm just going to present is, you know, the idea that all of this is here now and available. In the past, we presented data and spoke theoretically about what it would be like to have these therapies for each other, for our patients, for our loved ones. And today, now, the present, these are all available. And they're not available just as a single drug together. The idea of combination is coming forward, and the idea that these therapies are in melanoma, and they're there not just for melanoma patients, but patients with other solid tumors, breast cancer, colorectal cancer, lung cancer, prostate cancer, where melanoma in the past was looking for a path to take. Now it's blazing the path that others are looking to take. So I used to have a very wimpy guy, and then I'd put these two guys up and say, now we have two therapies that are strong, durable, and they work. But this year, I went to this. We have multiple therapies. These are the expendables. You can take, you know, Stallone and Norris and put them together. You got more, you know, more people come into the movie than just Stallone. But we have so much, and we have so much work to do and to benefit patients. And that comes from this slide. This slide was presented by Kim Margolin, who's in Seattle. And this was discussed after the first-line data on ipilimumab, known as Yervoy, and vemurafenib, known as Zelboraf, the BRAF inhibitor, were presented for the first time to all oncologists to understand. And Kim Margolin said one major thing: we need to be able to combine these things. We need to find something that works so good here that you can see patients are not progressing. They're benefiting right away. We see that with BRAF therapy. There's a Lazarus effect. The patients who are getting worse quickly turn around within 72 hours. But we didn't see that with immunotherapy alone. You see this? This is, nothing is happening until this magic moment weeks into therapy. And some of you have heard me talk about the fact that you can grow the amount of disease you have before you get a response. And it's great that we have this, but imagine taking this curve and then at this point here putting in the immunotherapy and moving up this number and taking this long-term survival curve and moving it up so that you're not just dealing with 0.2, which is 20% of the patients that started, but you're dealing with 50% of the patients who started getting long-term survival. So what I'm going to present to you is just articles that were presented and trials that are open. I'm not going to talk to you about what we did in the mouse or what we want to do. This is what we are doing, and this is open at Memorial, at MD Anderson, at Dana-Farber, at Angeles, at UCLA. These are available for patients. And so I find it interesting that when I was going through my slides and I saw this one, it says melanoma drug succeeds in late-stage trial. I said, oh, that's the PD-1 article. I wanted that lower down, but this is not the PD-1 article. This is an Amgen drug, T-VEC, which is an injectable into melanoma tumors. And early data showed that it can stabilize disease in some patients. And early data has shown that it may be a good combinatorial with another immunotherapeutic approach. And basically what it is, it's a herpes virus that goes into the tumor cells preferentially and causes those cells to die off, but has an immunotherapeutic systemic response that can go to other areas and cause disease to regress. That's unbelievable, but it's believable. These are the tumors that were injected on this patient at baseline. And this was the only area that was injected. 6 weeks later, you see that not only is this area shrunk and you see only pigment, but you see the other area around it starting to respond, and the local area starting to respond. These tumors have now flattened out and shrunk. And this happens, but the other idea was what happens elsewhere, distant, at the metastatic sites. And here's one patient that you can see here at 3 months, the liver lesion's beginning to respond and is gone at 6 months. That's wonderful. And what's even more wonderful is that by the time this data was presented, we had already started on a trial of combining this T-VEC Amgen drug with ipilimumab. That's available now, and T-VEC with BRAF inhibition is coming. Unbelievable. We also started taking that idea of combining immune-targeted therapy. And IDO is a local thing that's expressed in the tumor that causes the immune system to be downregulated. It's a brake on the immune system. We know that expression in human tumors is associated with decreased survival, and melanoma is there, but not just melanoma, ovarian, colon, pancreatic, acute leukemias. And now we have a drug that targets it. We know it's expressed in the tumor environment. We know that it can suppress host immunity, and therefore the ongoing trial is a combination of this drug, an Incyte is the company that makes it, an IDO inhibitor, along with ipilimumab. And some people sitting in this room are on that trial. That's happening. We talked about BRAF and we talked about ipilimumab. 2 years ago, it was all we had to talk about. And this year, we're combining them. And not only are we combining them on this trial, this is proof of fact that this trial is ongoing. It's already started at Dr. Who's site at MD Anderson. It's already open in Vanderbilt with Dr. Sossman and Dr. Puzanov. And it is looking at dabrafenib, which is the BRAF inhibitor that Dr. Boasberg talked about, with ipilimumab. But clearly, by the time this idea came out, we had moved forward to combination therapies. You heard Dr. Boasberg talk about BRAF and MEK. So wouldn't it be nice if we could take not one drug and give it to patients, not 2 drugs? Let's do 3 drugs. Let's put it together. Boom. There it is. So BRAF, MEK, and ipilimumab coming together on a trial and available for patients. And this is ongoing. Accruing will be open at the Angeles Clinic, is open at MD Anderson, it's open at Vanderbilt, and other sites coming. Here's where I initially thought I was when I saw that Amgen article, and this is a Nature Medicine blog, and it talked about the FDA granting breakthrough therapy designation to the Pdl-1 inhibitor that Dr. Ott presented to you a couple of talks ago. That's wonderful. And this data will be presented at the Clinical Science Symposium. But usually in the past, this is what it took. Let's present the data, let's talk, let's see the long-term data. But that's not what's happening. You saw this great response and we have to do better. You saw this huge durable response, but we have to do better. And that brings us to the next. For those of you who don't know, this is Jed Wolchuk. He's responsible for Dr. Richard Carvajal and the group at Memorial Sloan Kettering. And Dr. Wolchuk presented data of Pdl-1 inhibitor in combination with ipilimumab. That is ongoing, and that is happening, and this trial is now open, looking at patients who get nivolumab, which is the Pdl-1 inhibitor, versus ipilimumab alone versus the combo together. And this trial is open throughout the nation in multiple sites. So you can see when Dr. Wolchuk presented this, the number of patients who will be presented in this talk at ASCO in 2 weeks is small. It's under 100 patients. But that's enough to take us into this huge trial looking to see if combination is better. These trials are there. And where does that take us? Well, we're fortunate enough not to just have 2 types of Pdl-1 inhibitors. We have 3 or 4. We have Pdl-1 inhibitors. And that's all come from immunotherapy for melanoma. And this data was presented by Roy Hurst of the drug that I'll be presenting at ASCO in melanoma. But this is presented in multiple solid tumors with a significant response rate. So in all, 29 of 140 evaluable patients, 21% exhibited tumor shrinkage significant enough to be called a response. But look at this. What they didn't tell you is that majority of these patients were pre-treated with the standard options, and they had no options. They didn't tell you that these are patients with lung cancer, head and neck cancer, gastric cancer. These are proof of principle trials that have gone and started in melanoma and moved to other solid tumors. And where is that going? Well, these trials are already open, and they've been open for at least 6 months. And this is the combination of that drug right here, the Pdl-1, along with Avastin. That's an anti-vascular antibody. It blocks the vasculature that's formed to solid tumors that allow the tumors to get nutrition and grow. And currently there is a combination with vemurafenib, the BRAF inhibitor. Okay? Any one of these trials 2 or 3 years ago would have made all of the investigators here salivate to just have one available. And all of these trials are available. All of these trials are accruing. And all of these trials have multiple seats to fill with patients. Again, the pathway, the BRAF, the RAS, RAF, MEK, ERK pathway is a pathway that we've known about for years. And we understood that blocking BRAF worked, and then adding MEK inhibitor, initially blocking MEK either dual together or on progression from BRAF inhibition, can help patients do better. And now we have ERK inhibitors. Great, good to know, but what are we going to do about it? And this is what we're going to do about it. That is being combined with the PD-1 antibody and being combined with chemotherapy and other inhibitors down those extensive pathways that my colleagues have shown you throughout the course of the day. This is open and this is available. The other point I'd like to make is these are not a one-off. If you had one of these trials, you're not excluded from the other trials. If you've never seen a PD-1 inhibitor, you gotta see it. You can see it first thing, second thing, third thing, but they're available. And 2 years ago, 3 years ago, before Yervoy was approved, we all knew the lean times where you would have 50 patients who would need a drug, but only 5 slots. It's not like that anymore. Hundreds of slots open at a time. It's just the dawn of a new day. Well, all of this typing, and this is wrong, these slides that have too much typing, all of this typing says, what the hell happens when I fail my BRAF? And we're answering those questions. BRAF failure can happen at many different parts, and there are many different drugs to combine on failure of BRAF. CTLA blockade, high-dose IL-2, VEGF inhibition, which we'll get to, and other escape pathways are being looked at. Clinical trial now looking at BRAF inhibition and VEGF inhibition is ongoing through the Melanoma Research Foundation Breakthrough Consortium. These consortiums are formed in order to get drug companies to work together to make this combination available. And it's looking at patients on vemurafenib alone, the BRAF inhibitor versus the combination. And this is ongoing. A very interesting drug that wasn't built for melanoma initially, but started out in a phase 1 trial. And ultimately, given what we saw, expanded into what Dr. Ott talked about. That small phase 1 trial where you see a little bit of benefit and then all of a sudden so many spots open. And these are patients with melanoma who were treated. XL184 inhibits the MET pathway, which is another escape pathway, and VEGF pathways. It's an oral drug, and it was FDA approved, not for melanoma, but for medullary thyroid cancer. But if you look at the melanoma data, you see that the disease control rate, the patients that didn't grow at 12 weeks is significant, 45%. And it happened in not only skin, cutaneous melanoma, but all those other melanomas that Dr. Carvajal got up here and said, well, we don't have much and things aren't happening and we got to do better, but it's happening. Look, there we go. We have responses, disease control rate in ocular melanoma. And you can see shrinkage in different types of tumors and ocular. These light blue ones are ocular melanomas, irregardless of whether they had a mutation or not. So clearly a drug that we need to get into the clinic. Guess what? It's in the clinic. It's at Dana-Farber. Dr. Ott and Dr. Hody and Dr. Luke. They're looking at patients treated with BRAF inhibitor and this drug together. These are escape pathways, and previously what we did was put this up and say, well, we need to target this, and we'll find a drug, but there are drugs that target all of this, so enough of that. What we didn't talk about is NRAS mutated patients, and the majority of people in this room are not only friends but patients. And when we first understood BRAF inhibitors and BRAF mutations, there was a subgroup that was left out. And that's not true now. We're looking at other inhibitors in NRAS mutated melanoma that have shown shrinkage of tumor and disease control, and those trials are ongoing. But where I started and where I wanted to go was the fact that we just haven't said it's all about targeted therapy or it's all about immunotherapy. It's all about all types of therapy. And even though we can sit up here and arrogantly say we're leading the way, we're still learning about how to treat our tumors from other solid tumors. And the idea of an antibody drug conjugate is an antibody that targets, like a guided missile, goes directly to tumor and targets a protein that's on there. And at the side is a linker that links a chemotherapy or some other therapy. This type of therapy was approved by the FDA for breast cancer, a Genentech drug called Pdl-1 that targets HER2, which is a mutation in breast cancer. But we're looking at this in melanoma with an antibody drug conjugate that targets ETBR. So the antibody targets ETBR, it gets in there, and I call it sort of like a Trojan horse with a Molotov cocktail. All right. So the Trojan horse is it lands, it gets internalized, and then it releases the chemotherapy. That's the Molotov cocktail. And it leads to tumor death and growth. When I used to give this talk, I'd used to scour the clinicaltrials.gov site for options for patients who had failed one therapy or the other, or chemotherapy. And I would find a few, and then I would talk about chemotherapy. Chemotherapy still remains an option for patients, but we have other options, and I'm happy to say that I could turn this into a 1-hour talk, but I will spare you that, and I'll let you know that there's more coming. And the idea that one type of therapy is enough has moved on to the idea that possibly combinatorial therapies, not to exclude surgery or radiation therapy, is the way to go, because there are trials of Yervoy and radiation. There are trials of surgery and Yervoy. There's a trial looking at patients who present with lung tumors that have metastasized and get resected and get ipilimumab in the adjuvant to see if that's the right therapy. So whereas I was scouring, looking for trials and looking for things to bring into the clinic, now we have furthered the therapeutic options for our patients.